Welcome to our 2021 Help and Hope Symposium. Hi, I'm Steve Spalding, Director of Care Services for the Greater Philadelphia chapter of the ALS Association. Thank you for joining us. This year, we hope to share with you the expertise and insights and stories behind some important decision-making and options that are available to families as they go along in this journey with ALS. As you watch these videos and hear people's experiences and hear experts, we hope that it gives you insights, gives you confidence, gives you knowledge, and helps you to have conversations with your loved ones as you make important decisions for yourself and consider all the options available to you. Thank you and enjoy.
Hi, I'm Alisa Coll, and this is Ann Cooney. We're social workers with the ALS Association Greater Philadelphia chapter. And today we're going to be discussing financial considerations and insurance when considering being trached and vented. So when someone is trached and vented, they require 24/7 care. And this means that they need someone physically with them 24/7 at all times in order to be able to address any issues with the ventilator or if the monitor were to go off or anything. They need to be right there to help them. So obviously that would be extremely difficult and impossible for one person to do that and be available and awake 24/7. So we wanted to discuss how you can get care in the home and what that looks like when someone is on a ventilator and trached. Typically, we recommend that you have 3 to 5 people in your circle that are trained in vent care, and that doesn't just mean it has to be a nurse. It can be any family member or friends. Anyone is able to be trained in the care. The reality is that insurance does not cover this care at home long term. So even though you really need 24/7 care, it's not a benefit that is covered. Medicare does not cover ongoing 24/7 care in the home, and most insurances follow the Medicare guidelines. There are some exceptions to this and some plans that cover care in the home, but it's very rare. So looking at the typical timeline when someone is trached and vented, typically they're in the hospital for that procedure. They would also receive a PEG tube if they don't have that already at that time. And then from the hospital stay, most often people are transferred to an LTAC unit, which is a long-term acute care hospital setting for further adjustment to the trach and vent settings as well as for family teaching. And from there, they're discharged to home. So the big question is, how do families do this? And typically, most families that we see that are home on the trach and vent have a real mix of care in the home, from private duty nursing, family and friends, and the limited insurance support as well in the very beginning when someone is first discharged home. So when you're looking at private duty nursing, the average, if you were to hire someone through an agency, the average cost is about $50 an hour. That's for an LPN that's trained in vent care. Now, a home health aide, which a lot of people have prior to being on a vent, that typical cost through an agency is about $20 to $30 an hour. However, home health aides through an agency, due to liability, are not allowed to do vent and trach care. So it would have to be a nurse that's at least an LPN level. And they start at about $50 an hour. We did some math, and there are studies out there, they're somewhat dated, but if you're looking at $50 an hour for 27 care, if you're paying out of pocket, that's on average about $438,000 a year, which obviously is astronomical. So how do you find care? This definitely seems to be the biggest challenge for our families that have a loved one that's trached and vented at home, is the availability of vent-trained nurses. And that's why we always encourage that people have family members and friends trained as well for backup, because you never know what could happen. If even a nurse on her way could get a flat tire and isn't able to get there to relieve the next person. You always have to have a backup, plan B and plan C. So how do we find care? Agencies that have vent-trained nurses, training family members and friends, again, as backup support. And then there's always out-of-box ideas that we encourage. There are websites to hire, such as care.com. Word of mouth, even within your community, if you know a family or friend that had someone cared for, that had one of their loved ones cared for, if they come with a good recommendation. A lot of times people will look at local hospital, like training hospitals, teaching hospitals or universities that have a nursing, respiratory, or physical and occupational therapy program, and they hire students. And this may be a way economically to save some money and not have to start at that $50 an hour cost. And you would teach them and train them in the care. Also, your local church or synagogue, they often have outreach programs, and they may be aware of caregivers in the local community, as well as your local senior center. They all may be resources to look to see if there are caregivers available in your community that are looking for work or willing to be trained in this type of care. Okay, Anne is going to address the veterans benefits and the waiver programs.
Thank you. So if you're a veteran and you've been deemed 100% service connected due to your ALS diagnosis, the VA does provide support and care for you to be either home on a ventilator or in a nursing facility on a ventilator. They provide at home 28 hours of home nursing per week. Home nursing means RN or LPN care, and they use contracted agencies to hire these nurses to come out and provide care. They do not provide any home health aid support with this program because all the hours are dedicated for nursing care. If you find that you need additional support through home health aides, you can apply for another program through the VA called the Caregiver Program / Veteran Directed Program. If you're approved, you can receive more money a month, more compensation to then go ahead and hire additional home health aid support in the home. Connecting with your VA team, your clinic team, to learn how to apply for this program is what you should do, and they will help you guide you through this process. If you're unable to be at home for whatever reason, then the VA can support your care in a nursing facility. They have contracts with local nursing homes all around our area where they would pay for you to reside there in the home, care provided for you there, and the VA covers that cost. The monthly compensation that you have been receiving prior to being placed in a nursing home would decrease once you enter the nursing home because now a lot of the funding is going to the nursing facility for your care. You would still receive compensation, but it would be at a lower rate. And again, your VA team could help guide you with that whole process and explain all of the particulars surrounding that. The one thing I think we've all kind of touched on is, whether, being at home through the VA or through the other program that I'm going to mention is staffing can still be an issue. Finding RNs and LPNs who are trained with vent care experience can be challenging depending on where you live. If you're in a more rural area, that always presents a much bigger task in finding these nurses. But we'll work extremely hard to try and find the caregivers that you need to be at home. The other program that offers support is called the Medicaid Waiver Program. This program was created as a way to provide people the opportunity to still remain in their own homes but receive nursing home level of care. So hence the word waiver, kind of waiving the nursing home to be at home for the care that you receive there. To be eligible for the Medicaid Waiver Program, you need to be financially eligible for Medicaid and eligible for Medicare. Our chapter, serves the Pennsylvania, New Jersey, and Delaware, the entire state of Delaware. So each state offers waiver programs, but each state kind of administers it differently. So one state may offer one form, another state may offer something different. So you need to really check in with the people that you're working through to apply for these programs to understand what would be applicable to you. The waiver program is based on income and assets, and again, every state has different guidelines, but if you fall within those guidelines, then you can be eligible for care within your own home. And what that means is they would provide basic home health aides, caregivers to help you with your personal care, but also depending on where you live, you may be eligible to have skilled caregivers coming in, meaning RNs and LPNs that can manage the trach and vent care needs, the suctioning, trach, changing, the PEG tube feedings. In certain areas, you can have those types of caregivers coming in to provide that care. And it is all being covered through the waiver program, so there's no money coming out of your own pocket for that type of service. Sometimes people with the home health aide component can have aides coming in up to 40 to 50 hours a week. It just depends on your need, and it depends on what they're able to provide. And again, staffing, finding caregivers, consistent caregivers, tends to be a growing trend with some difficulties regarding that. But hopefully we're going to come out of this COVID era and all those things are going to improve some, and that will be a very good thing. Let's see. If for some reason you can't be in your own home and nursing home placement is required, then you can go to a specialized nursing home that provides vent care. There is some Medicare coverage for that. Typically, they'll cover for about 3 months' time, and then after that 3-month time period, the Medicare coverage would stop, and at that point, you would either pay privately to the nursing home, or if you're eligible for Medicaid, you would apply for what we call a nursing home grant that would cover your stay in the nursing home. So nursing home, placement is an option. It's a little bit more challenging because you need to find a facility that can handle a vent patient, but those facilities are there. Excuse me. Another thing, in trying to navigate all of this, many of our families seek the advice and support of an elder care attorney to help them understand the resources that they have and how they can maximize these resources and kind of figure out how they can manage this type of care, whether it would be at home or in a nursing home, kind of trying to maintain the assets that they have as well. So it's always a very good idea to consult with an elder care attorney because they can really guide you as to how you can manage this process best. We hope that this has been helpful in understanding the needs of patients who require non-invasive and invasive mechanical ventilation, being prepared to provide this care, good communication with your families, knowing what your wishes are from the beginning, and kind of having these conversations as you go throughout your ALS journey are so important to, I think, determine that you get the care that you want to have. You're in control. We stated earlier, just the consistent communication will encourage more positive experiences, and we, as your chapter social workers, are here to help you through this process, answer your questions, and support you every step of the way. So thank you so much for listening with us today.
Hi, my name is Gail Houseman. I'm a nurse with the ALS Association, and I'm here to talk about invasive mechanical ventilation and some of the nursing and other considerations related to this choice. So the differences between ventilation, there's non-invasive and invasive. Non-invasive involves a mask or some sort of mask over the nose or the nose and mouth, which is connected to a machine that helps the respiratory muscles. Those machines are called, some people are on BiPAP, other people are on Trilogy, other people are on something called a Voxen. And these machines provide inspiratory pressure, so pressure when you're taking a breath in, and they help the respiratory muscles to take a better breath in. Initially, these machines are often used just at nighttime, and the goal is to support inhalation. Hopefully, with this type of machine, you're going to feel a little more energy because you don't have to work as hard to breathe. And some people use these machines 24/7. Okay, like it might start out as at night, and then you start using it more and more. Invasive mechanical ventilation, the difference is it involves a ventilator, a machine that does all of the work for the respiratory muscles. So the ventilator is hooked up to a surgical hole in the throat called a trachea. And from there, the machine does all of the work of the diaphragm. So it takes over the breathing. If you choose this option, it requires a 24/7 awake caregiver. And that's mostly because people need to be suctioned that have this type of device. I have heard on occasion that there's some caregivers have told me that their loved one is fine at night and doesn't need to be suctioned. And so, there is some variability to this. I just wanted to, so I've been with the chapter for 21 years now, and I just wanted to relay my experience with invasive mechanical ventilation. The very first person I ever heard from 21 years ago, I got a phone call, and it was from a mom, an elderly mom, and she told me that her, I'm going to guess he was in his 30s, year-old son, was invasively ventilated, and that he was coming back to their house to live. 2 elderly caregivers. The mom told me that she had some training, but not that much, and that as far as she knew, there was no home care arranged. Nobody to come to the home like a nurse to teach them to make sure that they're okay taking care of their son. And the mom's question to me is, what do we do? My second experience was I was asked to see a patient in a nursing home, a skilled care facility that took care of people on ventilators. And I'm going to guess she was in her 60s. She was unable to communicate. There was no visible independent movement. It looked like she was not able to blink or move her eyes for yes or no. When people are paralyzed due to ALS, a lot of times their eye movements, they're able to move their eyes back and forth. And so, you move your eyes to the right for yes, you move your eyes to the left for no. I couldn't get her to do that. And the really frustrating part for her and me was that she looked like she wanted to communicate. She looked kind of almost panicky, wanting to communicate. Her husband was there. He said that his wife had developed respiratory distress. He called 911. She was intubated on the spot, and then eventually transferred to a skilled care facility. And the husband had told me that there was no advanced care planning prior to the 911 call. So challenging situations, both of them, and what I've learned over the years from those experiences and others is that there's really a need for people to be educated about their choices. And whatever they choose, what that would mean as far as care going forward. My sense is that education should start early on. Prior to having any kind of an emergent event. I mean, I know you can't always say when somebody's going to go into an emergency, but usually there's signs and symptoms that people have prior to going into respiratory distress. Another thing that I learned is that you have to have enough people to care for people. So 2 elderly people caring for a 30-something-year-old son is probably not enough. And that skilled home care needs to be arranged prior to the person being discharged. So all hospitals, all facilities have people that arrange home care and equipment so that there's a smooth transition, hopefully, from the facility to home. And if the person has, a ventilator, then certainly all care should be arranged prior to, which would include an RN and hopefully a home health aide to help with the bathing. And in addition, also a respiratory therapist to come out as soon as the person's discharged. Skilled care is usually covered for a period of time by the person's health insurance. It's rarely beyond a month, but usually you can get at least a month of people that'll teach the caregivers how to take care of the person. Another thing that I've learned, especially this one over the years, is that advanced care planning should begin shortly after diagnosis and should include disease progression. One of the really challenging issues with ALS is that the disease continues to progress, and that would include the breathing muscles and also communication. So we're hoping that people talk about their healthcare wishes with their families and their healthcare teams, and that this is an ongoing presentation. And that also that communication be addressed prior to. So some folks with ALS, it might start with the muscles that they use to speak. And so, what happens with those folks is that it's best to, however they are able to speak or communicate, whether it's through an iPad or a phone or a fancy computer or a board, that they communicate what it is that they want. Suggestions. Again, communication. Talk to your healthcare folks, talk to your families, meet as a family, include children if children are in the home. Children are they're going to be curious. They're going to know that something's up, and they need to be part of the discussion. For folks that decide to go with invasive mechanical ventilation, my suggestion is to communicate how long you want to be on the ventilator. I'm sure that's not an easy conversation, but so some people on invasive mechanical ventilation say, I want to stay on the ventilator at all costs. I don't ever want to come off. Other people say, I want to come off the ventilator if I reach a certain point, and they would identify what that point is. Quality of life, lack of communication, whatever. I mean, people have different reasons to go on a ventilator. Some people want to see, a wedding or a graduation or something. They want to be around for so long, and then they say, and then I'm done. Other people say, no, I want to keep going. The important part there, though, is to communicate. Look into care. For instance, who's going to provide the care, the financial end of care, the availability of care prior to the need for invasive mechanical ventilation. As Anne and Melissa are going to talk about in their presentation, they're two of our social workers. There's some places in our area that it's hard to find care. It's especially been hard to find care with the COVID. And then you want to look at your home. Is my home accessible? What do I need to do to make it accessible? Should I move? Those kinds of things. And then look into transportation. So for instance, somebody who has a ventilator is probably going to be in a power wheelchair. And a power wheelchair is not something that you can just put in like the trunk of a van or a car. You have to have that van transportation for that. So you can speak to your social workers about that, about purchasing a van, renting a van, and finding other resources for transportation. So potential positives of being on a ventilator, the biggest, I think, is that you'll most likely live longer. I mean, a lot of people with ALS, they're it's an average 2 to 5 years after diagnosis. There's plenty of people that live beyond that, but if you choose invasive mechanical ventilation, your chances of living longer are much higher. You could live for years on a ventilator. Again, you might want to stay alive long enough to see, a special event, like, a wedding or the birth of a grandchild. You might feel as if your quality of life is good, or at least, decent. You might find that after getting everything set up, care, equipment, etc., that you have what they call a new normal with your daily living. And then, rarely, but occasionally, some people with ALS on invasive mechanical ventilation are still able to work and or be involved in activities or projects that are important to them. potential negatives to being on a ventilator. If you look at the studies, some of the studies suggest that the quality of life for the caregiver, for the primary caregiver, is poorer than the person on the ventilator. So you have to consider your caregivers. There's financial concerns that the social workers will talk about: care, housing, transportation. Sometimes we find that there's discrepancies between what the person with ALS wants and what the caregiver wants. So we've had it where some people want to go on invasive mechanical ventilation, but their loved one doesn't want to take care of them and doesn't want them to come home, or the other way around, where the person doesn't want to go on the ventilator and the loved ones are really pushing him or her to do so. So that's why communication is so important. Another thing to consider is that ALS continues to progress despite the ventilator. So some people go on the ventilator and they're still able to maybe move their arms, maybe walk. Occasionally I hear about people on invasive mechanical ventilators that are still able to eat by mouth, which is rare, but there are some. And then, very sadly, and, eventually all of these voluntary muscles die. So the disease continues to progress. And then there's always the potential of not being able to communicate effectively. Alisa Brownlee, who's our assistive technologist, will be talking about that. So I started out with my experiences and I'm going to end. So I'm 21 years later. What I found in my 21 years, and of course this is just my own opinion and it's a generalization, is that some people, including the people with ALS and the caregivers, seem to manage okay, eventually, as long as they have what I have is their ducks in a row, and that means all of the equipment, caregivers, accessibility, communication, as long as they have everything set up. The people that choose not to go on invasive mechanical ventilation usually go on either a palliative care program or a hospice program. And they still continue to use their BiPAP, Trilogy, or Voxen for respiratory support. That some people qualify for skilled care in the home, either through their health insurance or the state waiver program, and the social workers will be talking about that. There's usually a period of adjustment for all. From generalization, it seems like it takes a little bit of time for everything to sort of come together, and that's normal. I think it's important to continue to assess the person's medical wishes. Persons on the invasive mechanical ventilator, do they want to continue? Is there a point where they want to come off of that? And I also think it's very important for caregivers to get respite time away, since their quality of life is impacted with the decision to care for somebody who is on a ventilator. Thanks for listening. If you have any questions about invasive mechanical ventilation, I would encourage you to speak to your physician and healthcare team, and feel free to contact me with any questions. My contact information, my phone number is 215-664-4134, and my email address is Gail, Gail, @alsphiladelphia.org.
So Gary and I met back in the 80s, and we were dating for a while. We went our separate ways, and later in life we found each other through Facebook, and we started dating again. And Gary had said to me through Facebook Messenger, I have bad news. And then he told me that he had ALS. Well, I blinked and I said, okay, let's still do dinner. That was cool. We had a great time, and we were joined at the hip since. I knew the severity of his disease just
I was familiar with his story when he told me all about his father dying from ALS. Gary was a young boy when his father died, and he remembered his father being at home in a wheelchair, and then he went into a nursing home, and that's where he died. And Gary remembered very much about what that memory was intact in his head. So making the decision about no ventilation was very easy for Gary because of the familial ALS with watching his father. And I supported Gary 100% on that. We both felt the same way. I have a long medical background. I have seen people with this disease, with a vent, without a vent, and I knew exactly what we were walking into. So we went through this journey together, and he was very, very clear on what his focus was for his quality of life. The quality of life for one person may be extremely different than the quality for someone else. And the caregivers, as supportive as we are, may not agree with every decision that the patient makes. However, it is their life, their quality of life decisions. He really was determined to make sure that his family and friends knew, hey, I'm gonna have a good time till the end. And he was very focused on not to have a ventilator because he knew it would just extend his life where he didn't want to go. Living with this disease, there are many personal decisions that an individual needs to decide. It is very important that you discuss these with your caregiver and know your intentions very early on, because as you progress with this disease, it is very difficult to be making decisions in the midst of a crisis. However, you need to make these decisions. Most importantly, it's really important that the caregiver is there to support any decisions that the patient makes. We may not always agree with every decision. However, the support structure is there outside of your realm. You have the ALS Association, your social workers, your nurses, your team that comes in and out of the house to help you. All those caregivers are here, and they will support whatever the patient's decision is. Caregivers, be advocates. Get to know your insurance coverage very well. Get to know what's included, what's not included, and tap into the ALS Association and your clinic, and make sure that you keep searching until you get an answer. It's very important that you tap into everything that's available for you. And there's a lot of organizations outside of your clinic and the ALS Association that can help you. Don't be afraid to ask. With this disease, it's very difficult. There's days where you just want to stick your head in the ground and life is not good to you. And you have to remember to focus on what you can do and not what you can't do. Make the best of every day and keep your sense of humor. You've got to keep your sense of humor because that'll help get you through everything.
Hello, my name is Dr. Maggie Kreher. I'm a palliative care physician in the Department of Family and Community Medicine, Division of Geriatrics and Palliative Care at the Thomas Jefferson University Hospital. I am also a member of the interprofessional team at the Weinberg ALS Center at Thomas Jefferson University Hospital. It's my great pleasure today to speak with you about advanced care planning. My goals are simple: to review why advanced care planning is important, to review the importance of a good discussion with your care providers and loved ones when doing advanced care planning, to review the types of advanced care planning documents available, and to provide you with some resources for advanced care planning that you can use to do advanced care planning at your own pace. And with that, we will get started with our slideshow. Why is advanced care planning important? It's really about the care you would want in medical emergencies. It's to guide your loved ones or proxy decision makers if and when you are not able to make decisions on your own. Advanced care planning provides clarity and peace of mind to you and your proxy decision makers. Most importantly, advanced care planning involves conversation with your loved ones, proxy decision makers, and your healthcare providers. Any documents support that conversation. Take advanced care planning at your own pace, and you can certainly change your mind as time goes along. It is important to remember to try to avoid crisis management because in ALS or in any setting, emergencies can happen. Knowing preferences and goals for care ahead of time assists healthcare providers in providing care in alignment with your preferences and goals. Your healthcare team may suggest interventions to support your goals and quality of life based upon your symptoms and clinical assessment. At each visit, specific types of impairment are assessed, such as in breathing and swallowing. There are non-invasive procedures and techniques, and there are invasive procedures and techniques involved in supporting the efficiency of your breathing and effectiveness of your swallowing. Non-invasive procedures can include positive pressure masks for breathing, especially at night or when sleeping, and non-invasive procedures such as dietary consistency changes to allow more efficient swallowing. Invasive procedures include tracheostomy, and I've included a picture of that here. A tracheostomy is a surgical procedure that places a tube through your neck into your main breathing pipe or trachea. Tracheostomies are usually designed to support chronic ventilation. Other invasive surgical procedure includes feeding tube placement, and a feeding tube placement is a surgical procedure where a tube is inserted through your abdominal wall and into your stomach so that you may receive liquid nutrition to maintain your calorie intake. As with most medical decisions, if not all medical decisions, it's important to consider risks, benefit, and burdens. What is the risk of the procedure? What are the side effects? What are the long-term side effects? What are the benefits of the procedure in regards to my quality of life, goals for care, personal goals? And what are the burdens of the procedure or intervention that can impact my day-to-day quality of life and day-to-day support needs? But every healthcare decision is personal and individual. Your healthcare team is there to provide expert advice, guidance, support, recommendations based upon all of the considerations of what's important to your quality of life, your goals for care, and your personal goals. And remember, knowledge is power to make the best decisions to support your goals. Collaboration with your healthcare team is key. Your decisions and goals may change over time. Conversation about your goals and values and views on quality of life with your family, friends, and support network is really the most important aspect of decision making. You need to provide guidance to your designated decision makers if you're not able to participate in healthcare decisions. It's important to understand the language surrounding advanced care planning documents. A living will is a document which states specific wishes for care at the end of life. A healthcare power of attorney is a document that designates a person to make medical decisions on your behalf. This person is only responsible for decisions if you are unable to make decisions on your own, or if you designate this person to make your healthcare decisions. A POST, or that's Pennsylvania Order for Life-Sustaining Treatment, is a set of specific orders signed by a healthcare practitioner and a patient or their healthcare power of attorney reflecting preferences for care at the end of life. An out-of-hospital DNR order is a document that is a medical order signed by a physician which applies outside of the hospital. And this is usually to not administer CPR in the event of cardiac arrest. Some facts about advanced care planning documents. Most of us in this country think that having our wishes documented is important or extremely important. However, a minority of us ever really document anything. But what studies do show is that family members who are asked to guess what a loved one's decision would be were accurate 50% of the time. However, studies have also shown family members who needed to make decisions on their loved one's behalf in the setting of a living will document had less stress around decision-making than those family members whose loved one did not have a living will. In essence, living will documents assist families have the least amount of stress around medical decision-making at the end of life. There are many types of advanced directive documents available. There is the 5 wishes document, and I will review that with you. There is the PULSed form, or orders for life-sustaining treatment. Most states have their own PULSed form, and it is a physician order set signed by the patient or their proxy. MyDirectives.com is an online site that can provide online documents for you to download. A living will, every state has its own state-compliant living will form. There is a website called caringinfo.com that is an excellent source for advanced care planning in serious illness. This is the cover page for the 5 wishes document, and the 5 wishes are: the person I want to make decisions for me when I can't, the kind of medical treatment I want or don't want, how comfortable I want to be, how I want people to treat me, what I want my loved ones to know. This document is considered a legal document in most states, not all, but most. It is a proprietary document, and you can go online and order one. It will cost you some money to download or have it sent, mailed to your home. This is a copy of the Pennsylvania Orders for Life-Sustaining Treatment, and as you look at it, you can see it's fairly complicated, but it does address specific medical interventions such as CPR, medical interventions when you are acutely ill, antibiotics, artificially administered hydration and nutrition. And it is signed by your physician and yourself or your healthcare proxy. The legal requirements for writing advanced directives include age over 18. You need to have capacity to make medical decisions. Most living will documents are legally recognized after you sign in the presence of a witness, only if you want them to be. The emergency medical technician's recognition of living wills and PULSed varies state to state. In Pennsylvania, emergency medical technicians must honor an out-of-hospital DNR. There is also state-to-state variation in terms of living will documents. Use your state-compliant documents if you find that easiest to do. Remember, your written directives do not expire. You can always revoke or destroy, and you can always change them. And also remember, as long as you're able to make your own decisions, you can make decisions that are different from your living will or other written advanced directive document. First and foremost in advanced care planning documents is to determine a healthcare proxy or a healthcare power of attorney. It is wish 1 from the 5 wishes document. A healthcare power of attorney should not be your doctor or other health provider or a person related to your doctor or your health provider. Your healthcare power of attorney would go into effect when you're not able to make decisions on your own, or if you have designated that person to act on your behalf. Again, I cannot stress the importance of discussion to discuss the role your chosen proxy has and discuss your views about care goals. because your healthcare proxy may be asked to make decisions about life-sustaining interventions, surgeries, medications, such as starting or stopping them. Your healthcare proxy may be asked to provide consent to transfer to assisted living facility, hospices, for example. And your healthcare power of attorney is allowed to legally represent you in health-related matters. Other directive documents to consider are CPR, or what is known as a DNR, traditional standard directives, or living will stay. If I have irreversible brain damage, or am permanently unconscious, or irreversible vegetative state, then I would want my care to flow this way. However, many end-of-life situations don't involve those three scenarios. And again, the conversation you have with your healthcare proxies or loved ones is paramount to good decision-making at the end of life. And again, in ALS, invasive medical decisions may involve feeding tube placement and tracheostomy placement. Advanced care planning relates to the decisions you make to support your goals and quality of life. It involves conversation with your loved ones and healthcare providers. A living will reflect your choices. Healthcare power of attorney designates your healthcare proxy to make healthcare decisions when you cannot. And a post or similar form is an order set signed by the patient and the healthcare provider outlining medical interventions to be provided at the end of life. But remember, care planning is mostly a discussion about living, how you want to live to support the best quality of life to achieve your goals. Your ALS team focus is to help you achieve the best quality of life and help you meet your goals. This focus is consistent with the philosophy of palliative care. Your ALS team is your palliative care team. These topics are tough to discuss and require time. There are many online resources out there to help provide a framework and to allow you and your loved ones to think about these things outside of the office or hospital. You can check out certain online resources such as youralsguide.com, 5wishes.org, eforms.com, which has downloadable living wills and DNR forms that are state compliant, and caringinfo.org, which is a great resource for having discussions in serious illness and provides links to state living will and healthcare power of attorney forms. I would like to thank you for your attention today, and I would like to thank the ALS Association for inviting me today. I hope you all have a great day.
Hello, my name is Leslie Vnechak. I'm a speech-language pathologist, and this is my colleague.
Hi, I'm Jennifer Scott. I'm a dietitian, and I work with Leslie over at the Penn Comprehensive ALS Center.
We're here today to discuss our roles as speech-language pathologist and a dietitian within the ALS clinical setting, particularly in the area of tracheostomy and ventilation.
Yeah, so I'll get started and talk a little bit about my role as a dietitian and what my goals typically are for my patients. Getting adequate calories is very important. You know, one of my goals is for weight maintenance. There is not a lot of research with regard to nutrition in ALS, but we do find that weight maintenance is protective. So a lot of my role and focus is to try and help patients get in adequate calories. This may change following a trach. So some patients may have a change in their swallow following a trach, which some patients may also receive a feeding tube. And this can be different from patient to patient. Patients may be able to eat the same following a trach, or they may have a change in their swallow and require some backup nutrition from a feeding tube. And we'll talk a little bit about this as we go through kind of our talk. One of the things we also may bring up is altered consistencies and trying to support just the ease of swallowing, and that is something that I will let Leslie talk a little bit more about as far as how we determine that for each patient.
So first, I'd like to start off with that each patient's process and presentation is different. So an individual evaluation is very important. So when we see a patient within clinic, we'd like to kind of do a thorough swallow evaluation. We start off with a clinical assessment. And what a clinical assessment looks like, we will take a look at the oral muscles of swallowing and speech and see how the muscles are working. We will also take a look at the patient-reported and family-reported swallowing difficulties. I'd like to know what's going on at home, what is difficult, what is easy, what's working for you. And then from there, actually doing a clinical assessment with food or liquid to see what is going well and maybe what isn't going well, and how maybe I could tweak some things or make recommendations within the clinical setting to see if it helps the swallow function. After that clinical assessment, I tend to recommend a gold standard would be an objective swallowing assessment. And there's two types. Depending on how someone is presenting within clinic would be what assessment we would recommend in collaboration with the medical team. There is a FEES study, which is a fiber optic endoscopic evaluation of swallowing. And that is done within an outpatient setting within a clinical office. It could be done by a physician in collaboration with a speech pathologist. And what that is it's a nasal endoscopy tube that is threaded through the nasal passage to get an aerial view of the laryngeal area. The laryngeal area is the entrance into your airway. So once that camera is in place, food and liquid is given to the patient, and we see what's happening. Is food and liquid going toward the esophagus, that's what we want, or is food and liquid going towards the airway? If it is going towards the airway, are there things strategies or postures or altered consistencies that we can introduce to prevent that from happening? The other standardized assessment or objective assessment would be a modified barium swallow. And that is done within radiology. That is a study that is basically like a moving x-ray. It's a movie of your swallow, and different consistencies and postures are implemented during that study to see what's going to help the individual swallow a little bit more safely and easily. Again, a speech pathologist is involved, and it is taking food and liquid by mouth or barium it lights up and we can see where it's headed. The goal is for food and liquid to head towards the esophagus, which then goes to the stomach. But at sometimes we see some things headed towards the airway, and we like to intervene live to see what would help to make that swallowing more comfortable, but also the safest way to swallow. And I alluded a little bit to some strategies and to altered consistencies. And when we say altered consistencies, this is different for everyone. It may change during the day, it may change with fatigue, it may change with positioning. But altered consistencies would be either making liquids a little thicker, so it slows down the flow of the liquid, so it's easier to swallow, or adding moisture to food, so it also is a little bit easier to swallow. The recommendations of altered consistencies or strategies or different postures to use are very individualized per the person. So it's very important that each person gets their own evaluation and discuss with the medical team about what's safest for that individual. At times, getting all adequate nutrition and hydration is not always applicable for everyone, and they may need support of a feeding tube. So I'm going to ask Jen to elaborate a little bit more about the feeding tube procedure.
Yeah, so like we talked about, those who opt to get a trach will oftentimes also receive a feeding tube. The name would be called a PEG, or a percutaneous endoscopically placed gastrostomy tube. And this is something that could be done in a procedure at the same time. That way you would only receive anesthesia one time, or it could be done separately. And this is something you would discuss with your doctor about, what would be best for you. But typically, if you receive a trach, you may also receive the feeding tube. The feeding tube would be there, like I mentioned, to support you, to make sure that you're able to get adequate nutrition and hydration. And it's not to say that you couldn't eat with a feeding tube. There's no contraindication when you get a feeding tube with eating, and that would really solely be based on what Leslie was talking about, how your swallow is doing and just your clinical presentation there. The feeding tube itself is a small, about a 1/4 inch flexible tube that when it's placed, it will extend from your stomach to the outside. So this is something that you would use and liquid would go through your feeding tube. So, think about like the consistency of a milkshake, or if you ever had, like an Ensure or a Boost, that consistency would be what I would recommend is what would go through your feeding tube. In addition, those feeding tubes can also use solely for hydration purposes, and some people receive them and really use them initially just for water to make sure that they're getting adequate hydration. And also your pills can be flushed down a feeding tube as well. So, depending upon what medications you're on, and you can consult with, the doctor or the pharmacist, but if your pills can be crushed, they can be crushed and flushed down a feeding tube, or if they can be changed to a liquid form, that also can be placed in the feeding tube. So this is really something, that is very individualized, like Leslie said. I mean, everyone will probably use their feeding tube differently. Some patients, it might be used as their sole source of nutrition. Others who are eating well or really don't need it that much may only use it sporadically or for pills or hydration. And this is something that can change, and that's why it's important to kind of discuss this with your team, with your dietitian, to kind of feel, to see how you can best utilize this, feeding tube. And also what goes through the feeding tube, and this is something that you can talk with your dietitian about, which is the appropriate nutrition formula that that they would order, that you would use for your feeding tube.
Something I would like to touch on that I had forgotten is that there is a risk of aspiration sometimes after a tracheostomy. So it is important to have these evaluations to see if food or liquid is falling below the vocal cords and into the lungs. Another take-home point I'd like to add to this is that your swallowing may change not only throughout time, but it may also change throughout the day depending on fatigue. So forming a relationship with your medical team and discussing different changes in any presentation is very important to ensure your quality of life, and we are definitely here to support you through that.
So yeah, I think that was it. I mean, for the feeding tube part, but maybe Leslie, you can talk a little bit about the communication.
Yes, so I do think there's going to be another section focusing on assistive technology, but I did want to address communication on a tracheostomy and when you're ventilated. After the procedure, again, it's consulting with your medical team, and it is a group decision with everyone on how to help you communicate best. Some patients may be able to tolerate a speaking valve, which is a valve that would allow airflow to go to the vocal cords, so you could verbalize. Some people may have difficulties tolerating that valve, and we discuss different types of communication, alternative communication, such as gestures, eye blinks, communication boards. We also get into more like speech-generating devices that would communicate for you. So again, that is an individualized evaluation with your medical team. All team members are a part of that, from speech pathologist, occupational therapist, physical therapist, physicians, to provide the support and help you communicate the best way for you at different times of the day and within your life.
I'd say, I guess we can kind of wrap up, but when making decisions, regarding your health, it's very individualized, and you want to make sure that you have this team or different people that you have to support you. And our role here is to support you and to help you make these decisions that are best for you at that time.
So thank you to the ALS Association for this invitation to speak with all of you about this important topic, and have a wonderful day.
Thank you.
I mean, especially knowing this disease will end up taking her away from us. It gives us a little bit more time with her on Earth. Yeah, she'll be there after no matter what, but it gives us time to spend with her. She kind of decided herself. We did talk about it between the family and clinic and the doctors to go with it. Also, I know she wants to see her daughter grow up, and instead of compromising her breathing, we decided to go with it. It was because of Elsie. She was just born. Heather was diagnosed a year after she was born. Heather's not ready to go, and she's a fighter. And I know she wants to see Elsie grow up, do all the things a child wants to do, and Heather's not ready to go yet.
Good job.
It kind of came out of the blue, really. She was having a hard time breathing, and come to find out it was her colon compromising her breathing. Didn't know it until after the trach was put in that all that happened. But will we know to this day if she needed it or not? We don't know this early, but I'm glad we did it. It's over with. She doesn't have to go through it anymore. It took her a lot of getting used to, because instead of her breathing on her own, I mean, she can breathe on her own, but now she's having something help her, and now she's got to time her breaths with the vent. Even when she was in the hospital about to get it, one of the nurses, Sue Walsh, came down and talked with us, helped us with the decision, walked us through whatever was going to go on, what's it going to take, the maintenance and keeping her healthy. We decided it was time. I mean, it's like, it's coming, you want it, let's do it. Just to be with your family, enjoy life. You only live once.
I don't think I really made a decision. I just knew that I wanted to see Elsie grow up, and I didn't really care what anyone else said. I mean, I think Steve felt the same way, but I really didn't ask him, LOL.
Good morning. My name is Dr. Ritu Grewal from the Division of Pulmonary Medicine and the Sleep Disorder Center at Thomas Jefferson University Hospital. What I'm going to be talking about today is respiratory issues in patients with ALS. I have no conflicts for this talk. So as you all know, ALS affects many different muscles of the body. It is a neuromuscular disease, and it can affect day-to-day living activities like turning in bed, walking, climbing stairs. It can also affect fine motor movements and impair handwriting, cutting food, and dressing and performing day-to-day hygiene. Most patients with ALS do not get diagnosed with respiratory muscle weakness until after the diagnosis has been made. And involvement of the respiratory muscles as well as the bulbar muscles can affect the respiratory function of normal gas exchange. And this can manifest in many different ways, like shortness of breath, difficulty lying down, and becoming short of breath, and ultimately it can lead to what we call respiratory failure. In addition, involvement of the bulbar muscles or the throat muscles that can impair speaking, swallowing, and also controlling the saliva can ultimately affect the function of the respiratory system. So to understand how the respiratory system functions, we should first understand the anatomy of the respiratory system. So the anatomy of the respiratory system involves the nose or the sinuses, the throat, the mouth, which is the lips, the tongue. This back of the throat is very important for maintaining patency of the throat muscles or the upper airway, so air can flow from the atmosphere into the lungs. So from the throat muscles, we go down into the windpipe. And the entrance to the windpipe out here is controlled by what we call the glottis or the vocal cords and the opening between the vocal cords. And the opening and closing of the vocal cords is very important to facilitate air moving in and air moving out. So if there's any weakness of these muscles, that can impair the function of the respiratory system. From the vocal cords, we go down into the windpipe or the trachea, and the trachea then branches into two tubes called the right bronchus and the left bronchus. And these airways further divide into very small branches and ultimately terminate in these small air sacs, which are surrounded by a lot of blood vessels. And this is where the gas exchange occurs. So for us to breathe properly, we need this entire anatomy to function properly. Now, there's a very important muscle called the diaphragm. This separates the chest cavity from the abdominal cavity, and function of this diaphragm is very important to facilitate that air movement. So how do we breathe? So to breathe, we have to generate what we call a negative intrathoracic pressure in our chest cavity. And to do that, we have to contract the diaphragm. The diaphragm contracts and it flattens out. And then there are these muscles which are connecting the ribs, when these are called the external intercostal muscles. And when they contract, they lift the ribs up and out. And so the chest expands. When the chest expands, we create a negative pressure within the thoracic cavity. So now air can flow in from atmosphere into the lungs. Now to breathe out, when we are breathing out quietly, it is a passive process. The diaphragm relaxes and pushes upward, and so that compresses the lung. The ribs turn down and in by relaxation of those muscles that I talked about. The chest deflates and pushes the air out, but we need this entire throat to be open so air can also go out. Now, when we breathe in actively, which means we take a deep breath in and we blow out forcefully, then we need a whole lot of other muscles to, especially to blow out forcefully, and some of these abdominal muscles come into play. And if these muscles are weak, then blowing out forcefully, as we need to do when we cough, that can get impaired. Okay, so let's expand on this a little bit more. So when we breathe, the diaphragm moves down during contraction. The external intercostal muscles, which are connecting these ribs, they contract. The ribs are elevated, okay? And so there's a change in the anterior posterior diameter, in the superior inferior diameter and the anterior posterior diameter. The entire lung cavity, the entire chest cavity expands, okay? And so air can now flow into the lungs because this negative pressure is created within the thoracic cavity. So air flows in from what we call from atmospheric pressure, which is at 0 millimeters of mercury, and then it flows in from a higher pressure to a lower pressure. To be able to breathe out, the diaphragm moves up. As I told you before, the ribs get depressed as the external intercostal muscles relax, and we are able to breathe out. And that breathing out is very important for carbon dioxide to be eliminated. So the function of the respiratory system is to facilitate air moving from the atmosphere into the lungs. Into the lungs, where the air oxygen is extracted from the air, and it goes into the blood and then distributed by the heart into the entire body. Now, carbon dioxide is a waste product of all the metabolism that occurs, and that carbon dioxide needs to be eliminated. So when the blood returns to the lungs, then carbon dioxide moves out into the lungs, air sacs, and by that process of expiration or deflation, carbon dioxide is eliminated. So what happens when we lie down flat? When we lie down flat and we are what is called supine, then the effect of gravity presses all the abdominal contents upwards and presses the diaphragm up. So when the abdominal contents move this dome of the diaphragm up, the lungs cannot inflate as much. Now, the process of going to sleep while lying down flat makes the breathing slow down itself. When we all go to sleep, our muscles relax. We tend to take smaller breaths. And because we take smaller breaths, oxygen levels go down, carbon dioxide levels go up. Now, in some stages of sleep, like REM sleep, then this process becomes worse because the muscles relax even more. So when this is what we call a hypnogram, or it's showing what is called the different stages of sleep as we sleep through the night. So when we first go to sleep, we are awake, and then we go into what is called a light sleep, a semi-deep sleep, and the first third of the night, we spend a lot of time in this, what we call deep sleep. All these stages are called non-REM sleep. So we have what is cycles of non-REM and REM sleep, about 5 or 6 cycles throughout the night. The first cycle is got a very small percentage of REM sleep, but as the night progresses, more and more of these cycles are spent in REM sleep, where the muscles of the body, especially the respiratory muscles, are very relaxed. And the respiratory centers don't respond as well to any changes in oxygen and carbon dioxide. So REM sleep is really not a good time for anyone who has any lung problems or who has any respiratory muscle weakness. The other function of the respiratory system is to cough. So what is coughing? Coughing is a sudden expulsion of air from the lungs through the epiglottis, through that glottis, that vocal cords, at a very, very high speed, so that it can eliminate any secretions that are accumulating in the airways. So normally in our airways, we have a lot of glands that can produce mucus in response to any irritation or any infection. So we need to keep these airways clear so air can flow in and out, and also because these secretions can also become a nidus of infection. So how do we cough? To be able to cough effectively, we need to take a deep breath in. So we fill the air up, we fill the lungs up with air. Then the vocal cords close, okay? So now all that air is under a lot of pressure. Okay, all the muscles are contracting and they make that air to be under a lot of pressure. Then the vocal cords open and we use our abdominal muscles, all our other expiratory muscles that come into play to be able to generate those forces to be able to push that air out. And while that we are expelling all this air, that high pressure will shear off all the secretions that are sitting in the airways and get rid of them. So to be able to cough effectively, we need our inspiratory muscles, we need our throat muscles, that are ones that are opening and closing the vocal cords, and we need all those expiratory muscles that come into play, including the abdominal muscles. So if there's weakness of any of these muscles, then the cough reflex is also impaired. So if the cough reflex is impaired, we use what is called a cough assist device. So it's also called a mechanical insufflator, exsufflator. And what it does is it gives a positive pressure so that the lungs can be completely filled up with air, maximal lung inflation. And then it abruptly switches to a negative pressure, almost like a vacuum. So what it does is it applies this negative pressure to the upper airway through this mask. And so it stimulates the flow and it rapidly extracts all the mucus that is sitting in the airways. So if the cough is impaired because of weakness of these respiratory muscles, one would need to use a cough assist device. So the advantages of the cough assist device is that it basically improves the cough force, the forces that are needed to generate an effective cough. It also stabilizes the breathing pattern, and because it's inflating and deflating the lungs, it can also promote chest wall flexibility. And because it's getting rid of these secretions, it can prevent hospitalizations due to infections, and it can also, studies have shown that it can also improve long-term survival. So what is the progression of respiratory failure in patients who have respiratory muscle weakness? The first thing that it occurs is that there's an abnormal gas exchange during sleep, especially during REM sleep, because all the muscles are so much more relaxed and the respiratory centers are not responding appropriately. And so this can lead to a lot of sleep disturbances that we can see on a sleep study if we do that. Okay, and then as time progresses, it will lead to symptoms of sleep disturbances, like patients will complain of interrupted or non-restorative sleep. They may complain of morning headaches, having a brain fog where the brain just doesn't seem to function as well. One would be tired during the day, be sleepy during the day. And as that abnormal gas exchange progresses to even being abnormal during the day, it can lead to shortness of breath with ordinary activity. Okay, and then patients can also start feeling discomfort when they lie down flat. We call that athapnea. And ultimately, it can also lead to a weak cough. Finally, it can lead to respiratory failure where someone is dependent upon a breathing machine to help them breathe both during the day and night. So how do we measure the lung function? How do we know when respiratory muscle weakness has set in? So what we do is when patients come to the ALS clinic, we do what is called a spirometry. And what a spirometry is, the patient takes a deep breath and blows as hard as possible into this tube, which measures the volume of air that is coming out. Okay, there's a clip on the nose and the technician is monitoring it. We can also measure the diaphragmatic strength by doing what is called a negative inspiratory force using this meter. Okay, we can measure how effective the cough is by making patients cough while they're blowing, cough into this what is called a peak flow meter and seeing the flow that is generated and then compare it to normals. And there are many different devices. This is one portable device that can also be used. So once the diagnosis of ALS is made, we assess respiratory muscle strength at every clinic visit. And what we are measuring is something called an upright and supine forced vital capacity. And the forced vital capacity is we make the patients take a deep breath in and then blow out as hard and fast as possible. And if the forced vital capacity is less than 50%, then we need to do something about it, because that means that there is impairment of gas exchange. We can also measure the negative inspiratory force, or that pressure generated by the diaphragm. And if the pressure generated by the diaphragm is less than -60, then we know there's abnormal gas exchange occurring during sleep. Other ways of checking is doing an overnight pulse oximetry. If the oxygen level stayed below 88% for more than 5 minutes, then we know that there is a problem. And we can check blood gases. If the carbon dioxide level is high in the blood, then we know that there is a problem. But what we normally do is something that is relatively easy to do when patients come to the clinic, is measure the forced vital capacity, measure the negative inspiratory force or the maximal inspiratory pressure, measure their cough peak expiratory flow rate, and then if they satisfy the criteria, we initiate them on non-invasive ventilation using a respiratory assist device. So what is non-invasive ventilation? Non-invasive ventilation refers to the provision of ventilatory support through the patient's upper airway using a mask or a similar device. So this is what it looks like. You may all have heard of a BiPAP or a CPAP machine. These are very small machines that can be kept at the bedside, and through a mask that either goes over the nose, sits under the nose, or sometimes covers both the nose and the mouth, it will deliver the pressures needed to inflate the lungs and also to promote deflation. If the respiratory muscle weakness becomes very advanced and someone needs assistance even during the day, we will go to a ventilator. And the advantage of a ventilator is that it is portable because it has a built-in battery. So if someone needs to go outside the house, they can put this ventilator on the back of their wheelchair, and they can go out of the house. We can also use multiple modes of ventilation, one for nighttime use, one for daytime use. And you can also do mouthpiece ventilation, which means just sucking on and taking a few deep breaths as needed. And this is what mouthpiece ventilation looks like. It's as needed breath delivery. It's given through this straw or angled mouthpiece. And one can just take a few deep breaths before doing something like eating or taking a shower, or when somebody just is feeling short of breath. And so the benefits are that basically it can enhance the speech, it can promote in swallowing, and it can just affect overall functioning and make somebody feel better that they're not hooked up to a ventilator all the time, and just use it as needed. So studies have shown that when we start assisted ventilation and we start the cough assist protocol and patients use it for more than 4 hours a day, they can live much longer than if they don't use anything. In fact, this one study showed that patients who used non-invasive ventilation and used it for more than 4 hours a day had a 33% lower risk of dying. So in the meantime, when patients do not have respiratory muscle weakness, what can we do to keep their lungs inflated? If they do not need any respiratory assist device, then using an incentive spirometer. This is this little device that patients use after surgery to keep their lungs inflated, and just using this a few times a day can help to keep the lungs inflated. The other thing that one can do is use what is called a respiratory muscle trainer, and that is basically taking breaths against resistance and blowing out against resistance, and just practice it a few times a day to keep the respiratory muscles trained. And again, there's no data for this, but we do provide this in the clinic, and as long as patients don't overuse it, I think it can help. But what's also important is that in some patients, they can actually monitor their respiratory function, do these tests at home, doing a home spirometry, and there are some of these devices that are available, and then the data can come to an app, and then you can transmit it to the clinic. I want to leave you with this one last slide, which is to practice good sleep hygiene. Sleep is really important to be able to function well during the day. So it's really important to give sleep a priority. We need to get at least 7 to 8 hours of sleep at night so we need to sleep for 1/3 of the night for the other 2/3 to function well. You want to treat any other sleep disorders like sleep apnea, because that can make oxygenation worse. We recommend that you use the bed for sleep and sex only. Avoid any alcohol and caffeine before going to bed, because that can impact the quality of sleep. It can also make respiratory muscle, especially alcohol, can make the respiratory muscles, can affect the function of the respiratory muscles, especially the upper airway muscles. We also say avoid long naps during the day, because then that impacts the ability to sleep at night. And it's really important to turn off all electronics and to sleep in a dark, quiet room. Thank you.
Hi, my name is Rick Gonzalez, and I'm a respiratory therapist who specializes in treating people that have breathing and airway clearance problems due to neuromuscular diseases such as ALS. I've been asked to briefly discuss invasive and non-invasive ventilation, and also airway clearance devices. So the main question, if you want to jump right into it with the breathing part, is a lot of people ask us, trach or no trach? It is still a personal choice, but I can tell you that clinically that you do not need a trach to breathe. I've actually had a patient that was over 50 years breathing non-invasively, never got a trach. It is necessary, however, if you are at risk of getting repeated aspiration pneumonias from your own secretions. In other words, you can't handle your own saliva. and secretions, everything keeps going down the wrong pipe and into the lungs. So that's being put very bluntly. The other question that typically follows is, what's the difference between invasive and non-invasive ventilation? Invasive literally means that you do get a trach tube put in. Non-invasive is using an external interface, very similar to what they use for sleep lab studies for CPAP and BiPAP. So they're external devices that you can use on the face. As far as the breathing machines that are used, a lot of clinics, they'll commonly order what's called a BiPAP machine. I'll do a little show and tell. This is an example, perhaps a little bit of an older model, but it is a BiPAP machine. This is the size of it. And then the interfaces, this is just a sample of one that would just fit over the nose. Okay. And they are commonly used. They do have limitations as far as their effectiveness. With all neuromuscular conditions, regardless of what issues you have, the lungs tend to get stiff. So it's very important to do what we call lung recruitment, which means to keep stretching the lungs out so we can use the full surface area of the lungs inside. Those machines can be limited over time as the pressures increase. They may not give as much air. There's also no portability. Unfortunately, you can't put one of those on a wheelchair. There's no battery backup and no alarms, if I hadn't mentioned that. Also limited controls for the clinician to make adjustments for comforts and settings. The other option, and the more effective one, is the non-invasive ventilator. This is an example of one right here. Okay, so that's a non-invasive vent. It can ventilate trach patients as well, but we use it in both ways. The advantages of the ventilators is that we basically can ventilate any breathing condition. Any problem you have, that machine does almost everything that the hospital machine can do. There are alarms. There's plenty of battery power that's available to it. That machine actually has an 8-hour battery built in, and you can add additional batteries to it. It obviously can be placed on a wheelchair very easily. Clinicians have a full array of controls for patient comfort and for effectiveness. The next thing that typically people like to see is, what is it that we're putting on our faces to make this work? So I just have a few samples here. And this is what's called a full face mask. And as you can see, it covers both the nose and the mouth. Okay. And this is just another sample of a similar type of device. Then we have smaller ones. And the reasons why there are so many available is because everybody's different, and what works for one patient may not work for someone else. This one is very small, and it just fits over the tip of the nose. It's actually too small for me, but for little people it does work. The nasal prongs are or nasal pillows are also called, are very common. So basically you would go over the head like this, and these prongs kind of go in the nose and back. So it's very easy to put on, actually, and you can still wear glasses and watch TV and read if you like with this particular device. It really doesn't get in the way very much. And then the other one that I showed very briefly is what's called a nasal mask, and the nasal mask literally fits just over the nose itself. So you do have quite a few options. We also have one more that is used a lot of times during the daytime. And that is, believe it or not, you can put a mouthpiece on it. And it would just go to the end of the tubing. And we could position this in pretty much anything from a wheelchair to a computer desktop, wherever would be convenient. And would basically right there, and the patient can still talk and just take breaths like this without having anything on their face at all. And I have patients that have zero ability to breathe, and they'll have this during the day, and they'll just do that and keep it right next to them. Okay, so moving along, That's a really quick overview of ventilation. The other part is the airway clearance. What's currently called the Cough Assist machine, there are different machines on the market, and they do have different names. It's basically a modern version of what was the Cougholator. The Cougholator was used back in the polio days, and it's went away for a while, and it's come back in the last 25 years or so, and there's modern versions that are very effective. The machine itself, I call it the pneumonia preventer, because it is the machine that will clear the lungs out and keep you from basically getting a bad pneumonia and having to go into the hospital. One of the machines that I have here, this is what it looks like, okay? And it can be used either with a mask, like this, okay? Or some people prefer it with a mouthpiece. And the way it works is that a natural cough is a deep inhalation followed by an explosive exhalation. This machine is almost a backwards cough. What it does is it gives you a deep breath going in, followed by a vacuum cleaner suction. So it actually goes, and then it feels like it's pulling out. It sounds a lot worse than it is. Basically, most people say it actually feels quite comfortable, and the deep breath part going in is just as important as the vacuum cleaner part, okay? The lungs divide 27 times. You can only cough from the top 7 segments up. So that's why a lot of people feel like there's secretions that it's always stuck in the throat, and it just can't clear it, the constant This machine will clear that. Once you use the mask is the most common one, and once you use the mask, pulls up, and it doesn't always bring the secretions up immediately, especially if you feel like there's a little bit of rattling in the chest. So it's not uncommon, about 10-20 minutes later, all of a sudden you find yourself trying to clear your throat or using the machine again. Once again, you can either do it that way or with the mouthpiece, and depending on how many secretions there are, some people can just use a napkin and just wipe a little bit into it. I have seen sometimes when people will just kind of use a cup and just expectorate a little bit into it. Also, it's very common that you can use a Yankauer tube, which is basically just like a dentist tube for mouth oral clearance, and this would be connected to a portable suction machine, and you would just go, and it would suck up and clean out the mouth and get everything that's in there. You wouldn't go deep, but just run the mouth. And that would be for the oral suction part of things. We typically recommend that you use the Cough Assist machine 3 times a day. The most important time is when you first wake up in the morning, because that's when you're most congested, just from laying down. If you can squeeze one in the middle of the day, it's just a good thing to do. A lot of people ask me, is there a type of physical therapy I can do for my lungs? There isn't a lot, but this is one of the things that kind of works from the inside, because it will stretch your lungs out, so it's very important. The last treatment, a lot of my patients tell me they'll sleep better if they clear themselves out prior to going to sleep. And especially if they are on a non-invasive ventilator of some kind, it just clears them out beforehand. That's basically the gist of it in a short time frame. If you have any additional questions, then you can reach out to your treatment centers, and I'm sure that we can get you more information as needed. Okay? So thank you for your time and your attention. I hope I was of some help, and be well.
Hi, I'm Alisa Brownlee. I'm an Assistive Technology Specialist with the ALS Association, and I thank you for joining me today for this presentation on assistive technology for people using invasive and non-invasive ventilation. So when thinking about assistive technology and invasive and non-invasive ventilation, obviously the first step is to talk about your respiratory plan, because each individual's experience with ALS can vary, and so too will their decisions regarding respiratory care. So your multidisciplinary care team or your healthcare provider can help guide a person with ALS and their family through this process. ALS will eventually weaken the respiratory muscles, and that will make breathing more labored. It's not uncommon for people with ALS to experience shortness of breath due to decreased lung function and diaphragm weakness. And as the breaths become shorter and shallower, the body receives less oxygen and is less able to expel carbon dioxide. So this can lead to fatigue, anxiety, headaches, lightheadedness, poor sleep, and bad dreams. Muscle weakness can also lead to hypoventilation, a state which the lungs fail to adequately expand, and sometimes this can increase your secretions, making breathing more difficult. So we use non-invasive ventilation, NIV, and what that refers to is the administration of ventilation support through the upper airways without using invasive artificial airways like a tracheostomy. So what people on NIV use is a face mask, as you can see pictured here, that usually goes over their mouth and their nose. It is easy to handle, it can be used at home. You know, most people start initially at night and then they may use it during the day. And that day use is where we can talk about communication issues, because it's very difficult to communicate if you have a full face mask on. And we'll talk about that as this webinar progresses. So the aim of NIV is to compensate for diaphragm weakness and alleviate carbon dioxide tension symptoms and improve patients' general condition and quality of life. NIV is associated with improved survival rates and better quality of life for people with ALS. And you can use NIV in your home, but you can also use it out in the community because it does have a rechargeable battery. In terms of invasive ventilation, this is a surgical procedure where a tracheostomy tube is placed in the throat, as you can see in this slide. And the procedure will prolong your life, but it can come at great expense to a person with ALS and their families. And it's important to understand that ventilator support does not slow the progression of ALS, so the disease will continue to progress. The individual decision to undergo a tracheostomy is a very personal one, and people often need a lot of time to think about it and what would life be like if I was what is called trach invented, which means you have a tracheostomy with a ventilator tube coming out of your throat, as you can see also pictured on this slide. It is best to make this respiratory decision well ahead of time, while the person with ALS can still fully express themselves and ask questions and discuss all the ramifications of this decision with their clinic or chapter team. In the United States, fewer than 10% of people with ALS do opt to get trach invented, and it is important to talk to your loved ones about this decision, because unfortunately Medicare and most insurances do not pay for people to come to your home to take care of you if you are trach invented. So the majority of your care will have to be by your family and your friends. And even if you do have coverage, we are in a severe shortage of workers right now. So you might have X amount of hours that your insurance will pay for, but you simply cannot find a trained professional to take care of you. And the majority of trach ALS patients are unable to speak, so we are going to address the communication issues when it comes to NIV and invasive ventilation. But before I talk about that, I want to talk about the importance of seating and positioning. Proper seating and position is critical for breathing, for communication, for computer access, for weight shifting, and basically just for living. Proper seating and positioning improves a person's ability to see more of their surroundings, to breathe and swallow and have better digestion. It allows for more comfort and less fatigue and greater ability to interact with the environment. And it distributes your weight so that you don't get skin breakdown or pressure ulcers. And it reduces your risk of falling. But for communication, it's extremely vital because you can't be in a listing position like it's pictured here on the slide. You have to be seated upright to use a communication device, but also just when you're seated upright and you're in a 90-degree position, it's also easier to breathe. And we have a lot of our folks that are in power wheelchairs, and they find that it's even more comfortable to sleep in their power wheelchairs than it is on a hospital bed. Sometimes that is because of breathing issues, because people who are short of breath, you know, you're going to elevate your head. But the wheelchair has functions like a tilt in space where you can tilt back and open up your airway a little bit, and you can also, some of them also recline almost into a position like a bed. So people who are using NIV, that's non-invasive ventilation, that still speak, as I mentioned in my previous slide, some people will opt to use NIV during the day. And what ends up happening is they can't communicate because they have a full face mask on. So if they can still speak, they'll take the mask off, speak, put the mask back on, take the mask off, put it back on, and that's really defeating the purpose of having the non-invasive ventilator on. So if you can still speak and you're using non-invasive ventilation, what you might want to try is an amplifier. And there are amplifiers with what's called a transdermal microphone, and that's what's pictured here down on the slide to the picture on the right. And the microphone goes around the client's vocal cords. So the microphone is resting on the vocal cords, and with the amplifier, the person can now speak. So they don't have to take the mask off to speak. You always want to have a call system for in the home. This is especially important at night when you are using your non-invasive ventilator or even your invasive ventilator, that you can get somebody's attention in the home to call for help. So the most common call bell system that we use is the MedLabs Easy Call Bell and Alarm. That's the one that's pictured down here on the right, and it has a blue button which only takes a ½ ounce of pressure to activate, and it's plugged in to an alarm that goes beep until the client stops pressing that button. You can also use baby monitors that have video or non-video, and so especially if your loved one is sleeping in a different room, so you put the Easy Call Bell and Alarm on the person with ALS, and if the caregiver is in a different part of the house or sleeps in a different room, they carry one of the baby monitors with them so that if the person with ALS rings the bell, the caregiver can hear the alarm go off no matter where they are in the home. If somebody still has hand function, you can use wireless doorbells. You can get these at a home improvement store, Lowe's, Walmart, and they cost about $15. So the person with ALS has the small portion with the button, and wherever the caregiver is, they're going to get a ding dong wherever they are in the house. There are adapted wireless pagers, and these can either make a chime or they can vibrate. So if somebody is has a hearing impairment and they might not hear the chime, the caregiver can wear the pager on, or they can put it in a pocket, or they can clamp it to their jeans or their pants, and they can feel a vibration instead of hearing a ding dong. You can use electronic doorbells or webcams as a signaler for help, or actually for just a caregiver to make sure that their loved one is okay. So these units hook up to a smartphone so that the caregivers, say they're out grocery shopping or they're out with their children, they can drop in and make sure that their loved one is okay. They can just hit the electronic they can actually activate the app and see the camera that's either in the home or wherever you've put it to make sure that your loved one is okay. Smart speakers are great for calling for help, but also for actually just being able to activate a smart home or even change the television channel. But in terms of calling for help, if one person has an Amazon, I'm going to use Alexa as an example, if they have that in the room where the person with ALS is, and then in another part of the house they have another Echo product, and they have the ones that have screens that are pictured here, they can see each other and make sure that they're okay. They can call for help, you know. So I have both an Amazon Echo and I have a Spot. The Spot is the one that's pictured in the middle. And what I can do is I can be downstairs, and that's where my Echo is, and I can tell Alexa, I'll say, Alexa, drop into the Spot. And so what that does is it activates the Spot's screen, and I can see what's happening in the room where my Spot is. Also, as I mentioned, smart speakers do give a person the ability to control their home. So there's so many different functions that you can do through your smart speaker. Television, you can look at the Ring doorbell that I just showed you. You can lock and unlock a door. You can activate a fan, lights. So they really do give a person with ALS the ability to control their home environment all through the use of a smart speaker. So I mentioned that for most people that are using invasive ventilation, the majority of them cannot talk. So we're going to address the communication options for people with ALS. And this is, of course, if you have a tracheostomy, but also applies for those that are just having difficulty speaking, slurred speech, which is called dysarthria. So our options for augmentative and alternative communication are rapid access. So these are easy, fast, efficient methods of communication that don't plug into a wall. You can use high-tech traditional mainstream devices like iPhones, iPads, Android tablets, and laptops. Then high-tech SGD, speech generating devices that are paid for by insurance. And what is important to know is that most people with ALS, when they have a communication difficulty, they will use multiple modalities of communication depending on where they are. The method of communication that you're using in the bathroom is going to be different than what somebody's going to be using in a living room or out in a community. There is no one system that people use. It's going to be multiple systems. And it is important to know that most of the communication breakdowns that happen in the home happen in the bathroom and in the bedroom. And if somebody does have an augmentative communication device, or if they're using their tablet, most of the time in the bedroom or the bathroom, that's where they don't have the device. That's where the communication breakdowns happen. So know that you're going to have to use multiple different systems depending on where the individual is. So the most important thing when it comes to establishing a communication system is that you have to establish a yes, no, and a maybe system. Please don't just ask yes and no, because you are forcing the person you are communicating with to answer incorrectly. So for example, if somebody said to me today, do you want to go outside, yes or no? Well, I don't know, is it raining? But I didn't give them a maybe. I just said yes or no. So always establish a yes, no, maybe system. You can do that through eye blinks, 1 blink yes, 2 blinks no, 3 blinks maybe. It's not my preferred method just because sometimes I miss a blink. Instead, I will usually stand at the foot of the bed or in front of the person, and I put my hand out to the right for yes, I put the hand out to the left for no, and my hands above my head for maybe. So I'm just watching their eye movement. But regardless of where the way somebody is saying yes, no, and maybe, always have it written down and hung on the wall. Because if somebody doesn't even know how to ask you these basic questions of yes, no, maybe, they're not going to be able to communicate with you. It's also important to put it on the wall in case you have to call first responders, that they can look at a person with ALS and say, okay, John, I see you say yes, bye. Okay, so the first responders are coming in. They're saying, John, are you in pain? Yes, okay, all right, and then they can just establish where. So rapid access can be the use of letter boards and picture boards and magic slates, boogie boards, eye gaze boards. Laser pointers are great. So you can mount a laser pointer on a hat or on a headband, and a letter board, which you can make on your own with a piece of poster board that costs less than $1 at Walmart. You put the alphabet or you put frequently used phrases and sentences on the poster board, and you can put that all the way across the room because a laser pointer can go a great amount of distance. So the person with ALS can be sitting halfway across the room and still spelling things out on the letter board. So you can see here's pictures of various different types of rapid access. In the middle is a picture of a laser pointer, and then there are letter boards pictured here as well as a boogie board. And what a boogie board is, it's an LCD tablet, basically. So you write on it, you press a button, and what you wrote has gone away. And you can buy them on Amazon for about $30. So these rapid access technologies are really important for emergency preparedness, because if you call an ambulance and you end up in the emergency room personnel needs to know how to talk with you. So just them knowing how you say yes, no, maybe is important, especially now during COVID. These rapid access methods can be used for an inpatient hospitalization, if you are emergently placed in a nursing home, for emergent ventilation. So if you haven't made a decision about whether or not to go on mechanical ventilation and you end up short of breath and calling an ambulance, and then you're taken in the hospital and given a decision, you either have to go on a vent or go home on hospice. And some people go, okay, I want to go home, I want an emergent ventilation, so that will be an emergency surgery where the tracheostomy is placed for you. And a lot of times that happens emergently. So, how are you going to communicate after this surgery? Rapid access is also important for mandatory evacuations. I think we've just this past year seen the devastation that's been happening in between wildfires and hurricanes and tornadoes. So sometimes you need to leave the house immediately, and so using these yes, no, maybe systems and letter boards are extremely important if you have to leave your home or if you have to stay in a shelter. So teaching people this method of communicating with you can literally save your life. And I don't say that to be over dramatic. I say that to be truthful, that it's a simple method of communicating with you, but you need to be able to relay crucial information to first responders, your medical team, and your family so that you can get your needs and your wants met. So there are devices that are funded by insurance. And AAC devices. AAC means augmentative and alternative communication. What that means is you augment your speech. So if somebody can still speak and they might have slurred speech, or they might get too tired during the day that they can't get enough breath out at night to speak, so then they'll grab their device. So that's augmenting your current speech. It becomes alternative when the client has absolutely no speech at all. So AAC means augmentative and alternative communication. In 2001, Medicare started paying for AAC devices. They were never funded prior to that. And at that time, Medicare called AAC devices SGDs, speech generating devices. So the terminology is interchangeable. I'm more old school, I still call them AAC, but if you are doing internet research or if you're looking at literature and it says SGD, it means the same thing. So insurance does fund these if you have Medicare with Part B and a supplemental insurance, and then some private insurances will fund either 100% or a portion of these devices. All private insurances follow Medicare guidelines. So Medicare has deemed SGDs or AAC devices are covered if the patient suffers from a severe speech impairment and the medical condition warrants the use of this device. So they are devices that can only be used for speech output. The devices cannot be useful to somebody without a speech impairment. That is a Medicare criteria. So Medicare does not cover personal computers, tablets, mobile devices that may be programmed to perform the same functions. All right? So that's really important because Medicare and insurance will only fund devices that have been deemed medically appropriate. And this is really important, that insurance will only pay for current needs, not future needs. So if somebody has decided, yes, I want to be mechanically vented, and they make that decision early, we as healthcare professionals, sure, we would love to get you all the medical equipment that you need prior to the surgery. But we can't if you can currently talk, because insurance only pays for current needs. And as the previous slide says, AAC devices are only covered if somebody has a severe speech impairment. So we can't get you that communication device prior to getting a tracheostomy if you can still speak. We can get it afterwards if you come out of the surgery and can't speak. So what you can do prior to getting mechanically ventilated, if you can still speak, you can obviously use a smartphone or a iPad or any other device that has a communication app, and then hopefully as you come through the surgery you can continue using it. But if not, there are loaner programs that you can borrow from both ALS chapter and an organization called Team Gleason. So for people that have slurred speech already, then yes, we can certainly go through insurance and get you an appropriate device. If somebody can use their hands, they can use what's called direct selection, so that's just using your hands to activate the device. If you do not have hand function, your options are to use a head mouse or an eye gaze. We're going to be talking more in depth about those in a couple more slides. But both the head mouse and the eye gaze can be added on later when clinically justified. So if you have slurred speech and need a communication device, you can get a tablet like pictured here on the right, and then we can add on the eye gaze or the head mouse later. And it is important to know that eye gaze devices are not funded unless the speech language pathologist can document that there are no other access methods. So again, we would love to be proactive and get somebody an eye gaze device, which is a device that somebody uses simply by eye activation, but that is not funded under Medicare or insurance until the speech pathologist can say, nope, they can't use a head mouse and they can't use switch activation. So yes, it's medically justified to get an eye gaze. So as I mentioned, AAC devices are funded under Medicare Part B, and your supplemental insurance would pay for the 20%. If you don't have supplemental insurance, you will owe the 20% because Medicare only pays 80% of the cost of durable medical equipment. With managed Medicare, most often you will get 80% of the coverage. Medicaid will vary from state to state. In Pennsylvania, we do have people getting devices funded under Medicaid, but I'm not sure about New Jersey, and Delaware often will pay for AAC devices under Delaware Medicaid. And your private insurance will just depend on your coverage. Sometimes you'll get 50% of durable medical equipment covered, sometimes it's 80%, sometimes it's 100%. It just depends on what is covered. And that is determined by what's called a rider. And every insurance policy has a different rider. So you have to call your insurance. Say you have Blue Cross, you need to call and say, what is my coverage for durable medical equipment? They might say it's 100% as long as you stay in network. Okay, that's fine. You might find out it's 60%. You might find out that you have no durable medical equipment coverage. So do not assume that you have coverage for durable medical equipment, which would include not only communication devices, but wheelchairs and commodes. Always call your private insurance and ask. And the Veterans Administration will fund communication devices as long as the individual is enrolled in the VA system. Communication devices are not covered if a person lives in a nursing home or is on hospice. So if you have a client that is residing, or if you have a person with ALS that is living in a nursing home, you can find out if they can get a device through Medicaid, or if they have private insurance, that might be covered. They are not covered, though, if you are only in a nursing home and have Medicare. So there are loaner devices that are available through the ALS chapter, as I mentioned, and then through an organization called Team Gleason. Just so everyone understands the process, if you want to go through and get a device from insurance, you have to be seen by an SLP, a speech language pathologist, who will do what's called an AAC assessment. So these are specialized assessments. Not every SLP does them, so you might have to go to a specialized facility to get this assessment. And I don't want to go through the minutia of the process, but just know that it takes quite a bit of documentation, and it's a comprehensive assessment. The SLP has to review everything from your medical history to your vision, to your hearing, to your caregiver's vision and hearing. They have to establish that you have no language issues. So it is a very intensive process that can take a couple of hours to do this assessment. And then after the assessment, the evaluation is sent to your prescribing doctor, who has to sign off on it. That doctor has to do a chart note, which is called a face-to-face, and has to also issue a prescription. Then everything is sent back to the speech language pathologist, who then sends this to the AAC vendor, who then bills insurance. And then once it's approved, you get your device. But I usually try to tell people this could be a 2 to 3 month process from start to finish. So from the time you go for the assessment to the time the device gets delivered to you. These are just some of the different eye gaze manufacturers that are in the United States, and they all do take insurance. Now, when it comes to mounts, communication devices that are funded under insurance can sometimes be heavy if they are, especially the eye gaze devices, you know, it's like 5 to 8 pounds, give or take. So you do want them mounted on a wheelchair, obviously to keep them safe and to prevent them from falling off. In the past, insurance has only funded one mount, and in the middle, as you can see here on the slide, is a picture of a rolling mount, and it's quite a large mount. Of course, it can roll around the house, but it's not really convenient to go out into the community. So then some people will say, oh, I want a mount that mounts to my wheelchair. Okay, but if you get one mount and it only mounts to the wheelchair, then the mount doesn't transfer if you're in a hospital bed. So you can try to ask the speech pathologist to get 2 mounts from insurance, or you can get a mount like pictured over here on the right. That's called a mountain mover. And actually it has a clamp that goes onto the wheelchair, and then the caregiver can unscrew or unscrew the clamp and then put it into a different clamp that goes on to the side of a wheelchair or onto the side of a bed. Onto the side of a bed or onto the side of a table. So the mount can go from the wheelchair to the bed or the recliner or wherever else the individual with ALS is. So some people will opt just to use mainstream technology like an iPad, an iPhone, whatever they're comfortable with. They might use this technology because they don't have insurance, or maybe, as I said, they're just comfortable in their current technology. Or they'll use alternative technology because they live in a nursing home or on their hospice and they know they can't get a device funded under insurance. So you can use an iPhone or an iPad, and there are different communication apps. You can get verbally for your iPad for free. You can get other iPad and Android apps for about $14.99. I love the app called Speech Assistant. I think it's a great app. And all these apps enable you not only to type out what you want to say, but they also enable you to say frequently used phrases and sentences, and you can bring them up and just press a button and it'll say, I need my eyeglasses. Many of these communication apps come in different languages, and if you do need a list of the alternative languages it comes in, please email me. You can access the iPad with your fingers or a stylus. You can buy a stylus of Five Below if you want to. But also built in to the iPad is called switch access. So that option is under accessibility. So when you turn on iPad switch access, you do need an interface. As you can see, there's one pictured here, this little black box, and you put a switch into it, and I'll talk about a switch in a second. And that black box acts as a Bluetooth interface. So when somebody presses their switch, the iPad will scan. It'll scan as you see pictured here. It'll go row, row, row. I hit my switch and it goes column, column, column. I hit my switch until it comes to the icon that I want. So that switch software is already built into the iPad. The only thing that you need is the interface and a switch. And so what is a switch? It's a piece of equipment that sends a current to the machine to do something. So picture a power wheelchair and a joystick. When the person presses the joystick forward, it sends a current to the machine to go forward. That's the same thing a switch does. It just sends a current to the machine, in this case an iPad, to do something, and it will start scanning. All right, so switches come in a variety of shapes and sizes. They can be placed anywhere on the body where there is muscle movement. In the new iPhones and iPad Pros, so you need an iPhone 10 or above, there is a front-facing camera, and there are apps that utilize that camera to activate eye gaze. So you can see the communication apps here. I Have a Voice and Hawkeye, Predictable, AAC, and Jabberwocky. They all use the front-facing camera so that you can, or on the iPad Pro or the iPhone 10 or above, so you can have the device in front of you, and it is reading your eyes to make activations on the screen. However, these communication apps only do communication. You can't use them for total access of the iPad. At the moment, that is only achievable through a product called the Skyle, and it's around $3,000. It's probably going to come down in price. It hasn't been around too long, but it does offer the individual total control of the iPad with their eyes. There are mounts that you can buy for iPads, iPhones, and Android devices off of Amazon, and most of them have a clamp so that they can go from wheelchair to the side of a hospital bed easily. If you're using an Android tablet, your access to Androids can be by a finger, by stylus, by a mouse or head mouse, or an eye gaze. So you have more access options on an Android tablet than you do on an iPad. You can also use a laptop for communication. There is free software that is available for Windows laptops that will basically turn your laptop into a communication device. If you can't use your hands, and if you still have good head movement, you can use a head mouse, which replaces the standard computer mouse for people who cannot use their hands. So what a head mouse does is it translates natural movement of a user's head into proportional movements of the computer's mouse pointer. So basically you are moving your head around the screen and making activations. What you end up doing is having a on-screen keyboard, and I'm sure we're all familiar with them. If you use a smartphone, you have your on-screen keyboard. That's how we send texts on a smartphone or a tablet. So you bring up an on-screen keyboard, which is already embedded in Windows and Mac. So you bring that up. You have a head mouse, which you have a receiver on the top of your Android tablet or on your laptop, and the user wears a reflector dot between their eyebrows, and so they are just moving their head around the screen, dwelling on the letter A, and it types the letter A for you. So it works just like a computer mouse, but instead of your hand moving the mouse, your head is. There is eye gaze control for computers. These are devices that turn any laptop or desktop to an eye gaze device. The more high-end are around $2,000. But know that Windows 10 has eye gaze software already pre-installed. So you can get an eye gaze bar. It used to be a Tobii 4C, I think it still is, for about $250. You can plug that into your USB port on your Windows computer, and you have eye gaze control of your Windows 10 computer. Of course, it's not as precise as the one that costs $2,000, but it does give you the option of seeing even if eye gaze is something that you want to do. And as I mentioned, there's free software that will convert any text that you enter into your Windows computer, and it'll say out loud. So each Riloquist is one. This is an example here. And again, this is free, so you can save frequently used phrases and sentences. You can write your own dialogue. And it also has fast fire, so that if I hit F1, it'll say, hello, how are you? F2 will say thank you, and etc. So some people that are on mechanical ventilation may develop locked-in syndrome. We don't have an exact statistic of the amount of people that develop locked-in syndrome, but it is something to be aware of. That locked-in syndrome has two formats. You have LIS, which is locked-in syndrome. It's the complete paralysis of all voluntary muscles except for eye movement. And then you have TLS, total locked-in syndrome, which is the absence of movement, including eye movement. So if somebody could still be technically considered LIS, locked in, but if they have eye movement, they could be able to answer yes, no, maybe questions and still might be able to use an eye gaze system, an electronic eye gaze system. People that have total locked-in syndrome have no eye movement, so there is no technology that has been developed that's commercially available yet that will enable somebody that has TLS to communicate. So it is important that you have your advanced directives written down and given to your family and your medical team prior to developing TLS. Now, as I mentioned, we don't know who might develop TLS, but always think of it as, okay, it might be something to consider. So I want my wishes known prior to that happening to me. And then with TLS, there also might be some eyelid issues and the person might not be able to hold their eyelids open anymore. And you do not want to tape them open because that can lead to torn retinas. So what is on the future for people with TLS and locked-in syndrome is brain-computer interface. This is in research only. And if you are interested in seeing more about this, I encourage you to go YouTube, look at some YouTube videos on brain-computer interface. It's also called BCI because they are making tremendous strides. And basically BCI is harnessing the individual's brain waves to activate a computer or a communication device. And I just want to finish up talking about emergency evacuation aids. These are aids that will get you out of the house in the event of an emergency. Everybody with ALS should consider having an emergency evacuation aid in the home. And this can be as simple as this tarp here that's pictured all the way to your left. This is about $55 for this evacuation tarp, which enables one person to wrap the individual up with ALS. I describe it like a burrito and pull. But it's not going to be comfortable per se for the person that's being pulled, but it will get you out of the house in the event of an emergency, whether or not that's fire or whether or not that's flood or a tornado coming. There are evacuation aids that are developed for the one in the middle. The blue one is developed for 2 people, and the picture on the bottom depicts that. So you have one person carrying the tarp at the knees and then the shoulders, and then the person on the other side is doing the other knee and shoulder. So, I can't say it, shoulder, there we go. And the picture on the right is basically just a backpack. It's a piggyback tarp that you put the person on your back and out you go. There are emergency evacuation chairs. These are chairs that are developed to get you out of the house or apartment or high-rise in the event of an emergency. And they come in several different forms. The pictured chair here that is yellow, you can see to the far right is just somebody being strapped in and taken down the steps. You will see these evacuation chairs a lot. Most of the schools have them. You see them in high-rises now. And the picture in the middle is actually a more sophisticated chair. That's an electronic chair, and you can see, I hope you can see on the bottom, there's almost a track, and that track will be responsible for taking the person down the steps electronically. So the chair that is pictured that is yellow is non-electronic. That's just, going down the steps, sort of bump, bump, bump. The one that has a track, the caregiver has electronic controls on a bar, and the machine is doing all the work for you. Also, everybody with ALS, regardless of the respiratory status, should have a go bag. This bag is kept near the door that you would use to exit, or you can have more than one bag if you have multiple exits. And the bag would be grabbed in the event that somebody had to call an ambulance or that you had to evacuate very quickly. And in the bag, you could have whatever you want. You can customize these bags. Now, FEMA has content suggestions that I have listed here, but the most important things would be having written phone numbers. Don't assume you're going to have access to your cell phone. You might have accidentally left it behind, or it might have died. So written phone numbers, communication boards if you have difficulty speaking, your copy of your advance directives. I always tell people to go to Five Below and buy a cell phone charger and leave it in the go bag. Promise yourself you're never going to take it out, all right? And if you do the Five Below, get the 10-foot, because if you end up in a hospital, you know, your outlet might not be right next to the hospital bed. So get the longest cord that you can. It's also recommended, of course, you have hand sanitizer, and for people who have a feeding tube, you might want to include some cans of enteral nutrition. That might be important if you had to leave the house and go to a shelter for a weather-related emergency, because shelters are going to give you hot dogs and hamburgers. They're not going to have cans of feeding tubes or, you know, enteral nutrition for you. So customize the bag the way you want, but always have a go bag near the door. Thank you for participating in this webinar, and if you have any further questions, you can feel free to email me at alisa@alsphiladelphia.org, or my phone number is on the slide, and I look forward to speaking with you in the future.